Welcome to the 5th AAPM Cares Education module about patient fetal and gonadal shielding. This module describes the work of the CARES Committee in the roles of various stakeholders in discussions of patient gonadal and fetal shielding. I am Rebecca Marsh, a medical physicist from Colorado and chair of the AAPM Cares Committee. The objectives for this module are to learn about the AAPM 2019 position statement, learn about why the CARES Committee was formed, and to understand concerns from various groups about this position statement and about the future of gonadal and fetal shielding. In early April of 2019, AEPM released a statement in the form of Professional Policy 32A. In short, it says that the risks associated with shielding patients' gonads or a pregnant patient's fetus outweigh any potential benefit. The full statement can be accessed at the link shown on the slide. With this statement, AAPM asserted that gonadal and fetal shielding provide negligible or no benefit to patients' health, and that the use of gonadal and fetal shielding can negatively affect the efficacy of the exam. In other words, the AAPM statement describes a risk-benefit analysis of the clinical practice of shielding a patient's gonads or the fetus of a pregnant patient. A more extensive discussion of the risks and benefits associated with patient shielding is provided in other modules in this series, but I'll summarize them here. First, let's look at gonadal shielding. Traditionally, gonadal shielding has been used during X-ray or CT imaging of the abdomen or pelvis when the gonads are in or near the imaging field of view. The amount of radiation used for these exams is typically very low, far lower than what has been demonstrated to cause harm to the gonads. Gonadal shielding has also been used when the gonads are far from the imaging field of view, such as imaging the extremities. In this case, the gonadal dose is already extremely low and often not even measurable, so shielding provides no benefit to the patient. The same concepts apply to fetal shielding. If the fetus is outside the imaging field of view, the fetal dose is very low. If the fetus is inside the imaging field of view, shielding will cover up anatomy that we need to be able to see. There's another important consideration. The majority of radiation to anatomy that is outside the imaging field of view is from internal scatter generated within the patient. Patient shielding will not absorb radiation from internal scatter. For all patients, pregnant patients, children, adults of childbearing age, the benefit to using patient gonadal or fetal shielding is negligible or non-existent. Any discussion of benefits should also include consideration of the associated risks. The AAPM statement delineates the risks associated with patient gonadal and fetal shielding. Again, this is covered in more detail in other modules within this series. But in summary, the risks associated with patient shielding include obscured anatomy, negative effects on automatic exposure control and automatic tube current modulation systems, both of which have been shown to improve image quality and optimize patient dose, increased dose to other organs, some of which are more radiosensitive than the organs that are being shielded, and degraded image quality. Aside from summarizing the associated science, the AAPM statement includes the following. Quote, for patients or guardians experiencing fear and anxiety about radiation exposure, the use of gonadal or fetal shielding may calm and comfort the patient enough to improve the exam outcome. This may be considered when developing shielding policies and procedures. However, blanket statements requiring the use of such shielding are not supported by current evidence. End quote. In other words, the AAPM position statement recognized that changing a long-standing clinical practice, especially one that many patients and healthcare workers see as an essential component of patient safety, has a substantial psychological component that must be considered. This is an important consideration, especially while imaging centers are actively changing their patient shielding policies and practices. So in summary, the AAPM statement provides a risk-benefit assessment of fetal and gonadal shielding. It only addresses patient gonadal and fetal shielding. It does not address personnel shielding, and it does not address other types of patient shielding, such as using breast shields or thyroid shields. It recognizes the psychological component associated with changing this clinical practice. and it's provided as a statement of the science. The AAPM professional policy was endorsed by several other healthcare organizations and supported by additional groups such as RSNA. The AAPM had released its position statement, and so the next question became, how do we get everyone together to discuss this topic? As a little bit of background, in the US, there are about 2,600 diagnostic medical physicists and medical health physicists. There are about 30,000 radiologists and over 200,000 practicing radiologic technologists. Looking at these numbers, it becomes glaringly apparent that any discussions of changing a long-standing clinical practice cannot be achieved by physicists alone. So how do we get everyone working together on this? How do we get people to have these conversations? We needed to figure out how to bring people together, how to bring together people from a range of specialties across medical imaging, including not only physicists, radiologists, and radiologic technologists, but also regulators, managers, referring physicians, and educators. All of these organizations and all of these groups and all of the individuals in those groups have patient care as a priority. There was just some disagreement about what constituted best patient care. To create a forum for these conversations, the AAPM Cares Committee was formed in April of 2019, just after release of the position statement. The committee was formed to help improve communication across subspecialties in medical imaging about the specific topic. This goal is reflected by the CARES acronym, Communicating Advances in Radiation Education for Shielding. The specific goals of the committee are to coordinate communication, not only with members of other professional societies, but also with patients and parents and caregivers. Also, we want to develop educational materials and consistent messaging that will help communications, again, among healthcare workers, but also with patients and parents. The CARES Committee consists of several AAPM members, with myself as chair and Dr. Sarah McKenney as vice chair. There are also representatives from a number of other organizations, including other medical and health physicists, radiologic technologists and educators, radiologists, and regulators. Many of the members of these groups were talking amongst themselves about patient gonadal and fetal shielding, but communication between subspecialists was limited. But before we could start working on developing communication strategies, we had to better understand the concerns and challenges that this proposed change in clinical practice posed for each of these stakeholders. Let us first consider the role of the radiologic technologist. There were concerns about what effect, if any, there might be on certification and professionalism. This was reflected by questions about, is this legal? And am I risking my certification by not providing patient gonadal and fetal shielding? Compared with other stakeholders, radiologic technologists have the most interaction with patients. This means that they are typically the ones faced with explaining any change in clinical practice, and it also means they bear the brunt of patients' and parents' questions and complaints. This can be particularly problematic in a busy imaging department where there are pressures to image patients quickly. It is not always practical to have a 10-minute conversation with each patient about the use of gonadal and fetal shielding. So we wanted to ensure that radiologic technologists were not only involved in conversations about the potential change in clinical practice, but also that they were supported by their radiologists and physicists colleagues. Let us next consider the role of the medical and health physics communities. Although there was more consistent agreement among these groups about the science that supports discontinuing gonadal and fetal shielding, there were a lot of concerns about how to effectively communicate with other specialties. There were concerns about not only what should be communicated, but how it should be communicated. The second question physicists had was, how do we support our coworkers? How do we help foster interdisciplinary conversations about this topic? And how do we develop policies that are not incredibly disruptive to the clinical workflow? How do we take some of the burden off of radiologic technologists and talk to concerned patients ourselves? Radiologic technologist educators had a separate set of concerns, including the effect on curricula and their certification exam. For several decades, education programs have placed a strong emphasis on the proper use and positioning of patient shields. This also means that there are extensive teaching materials, textbooks, course materials, exam content, that are based on the importance of shielding patients. How could educators even begin to redirect these educational efforts? To complicate matters, there are multiple groups involved with determining educational content and exam content, including the ASRT, AIRS, JRCERT, ARRT, and others. Radiologists also had concerns. How would they communicate this change in clinical practice to non-radiologist MDs? Imaging exams are almost always ordered by physicians outside of radiology. How would radiologists explain to their colleagues that their patients would no longer be shielded during their X-ray exam? And would patients be confused? Would referring physicians be willing and able to explain this change to their patients, or would patients be getting conflicting information from different physicians? The first role of the CARES Committee was to facilitate conversations among medical imaging specialists. We had many conversations about concerns and challenges faced by different groups, which created a much better understanding of how to address changing a long-standing clinical practice. These conversations also enabled us to start developing effective educational resources about patient gonadal and fetal shielding. The first was a frequently asked questions document released in December of 2019. This document consists of 3 sections. The first is written for those who work in medical imaging, including technologists, physicists, and physicians. The second section addresses questions that may be asked by patients, and the third section addresses concerns specific to parents and caregivers of pediatric patients. This document also includes suggested phrasing that can be used in conversations with healthcare professionals and parents and patients. The CARES Committee has also helped facilitate inter-society collaborations, which has improved communication and understanding between specialties. Most recently, the committee has developed an initial set of education modules, one of which you're watching right now. And we've also established ways to help disseminate information and to allow anyone to contact the committee with questions or concerns. There are other resources available about patient shielding, including this document written by a group of British organizations. This document, entitled Guidance on Using Shielding on Patients for Diagnostic Radiology Applications, discusses the use of patient gonadal and fetal shielding, but also other types of patient shielding, such as breast and thyroid shields. This document is available on the British Institute of Radiology website. In January of 2021, the NCRP released its recommendations for ending routine gonadal shielding during abdominal and pelvic radiography. It is important to note that the NCRP statement is more limited in scope than the AAPM statement and only addresses patient gonadal shielding, not fetal shielding. Further, the NCRP statement only addresses in-field gonadal shielding during X-ray exams. The NCRP statement also has 2 accompanying documents, one that addresses communication strategies and a pamphlet that can be distributed to patients. All of these materials can be found and downloaded from the NCRP website. The CARES Committee is committed to ongoing, meaningful conversations. We encourage anyone and everyone to reach out to us with any questions and concerns that you have. You can reach out to us via email or on social media at Facebook or Twitter. I'd like to also acknowledge all of the contributors to the CARES Committee. I am fortunate to be able to work with such an amazing group of talented and caring individuals.